across the partnership to make sure that that was as a key focus for us. We also did some work around improving quality, around safeguarding self-neglect pathways. We've done a lot around strength-based approaches and practice across the teams. We've done a lot around making sure that there's managerial authorisation processes in place, which sounds simple to do, but when you're working across two very complex systems, that's taken a number of years to kind of unpick, undo and put back together so that the workforce understand their responsibilities and that we are delivering better outcomes but within the resources that we've got in Kirklees. I think we've done a lot of work around nurturing and skilling our workforce up across that footprint. And I think what we've got now is a really strong partnership there where we do everything together. We've got joint processes, we've got joint protocols, and we've got joint policies, which sounds like something that we should have had anyway. But certainly wasn't in existence when I took over as head of service then, now service director. We have regular team-to-team meetings. We work together collaboratively. We've got, like I said, we've got real strength in the management, and ultimately we've created a social care hub where we have an independent hub that does all the social care work and focuses on our responsibilities. So we are now meeting our duties in terms of AMP work, which is the Approved Mental Health Professionals, and our duties under the Care Act. So it's been a long journey. It's taken us at least 4 or 5 years. We did a lot of work during the pandemic to make sure that there was still that strength. We came together through team meetings and making sure that that work continued. We recruited key posts during the pandemic, including deputy managers and the service manager. And they built up relationships with all the teams across the mental health footprint. So I think, you know, we've come a long way. There's still more to do, but I think when you look across Kirklees, Calderdale and Wakefield, our partnership is really, really strong compared to the authorities. So I think we've done as much as we possibly can, but like I said, we're still on a bit of a journey, but it's been great working with our colleagues in the trust. But like I said, it's been something that we've all been really, really passionate about, making sure that we are providing better outcomes for the citizens of Kirklees. Okay, thank you.
Thank you. Thanks, Michelle. I was just going to speak briefly about the acute pathways, and again, the information on this is in the pack. But I think just drawing attention to really the intense pressures that have been experienced in the acute pathway and the levels of distress and the levels of complexity that people who have been in a position of having to come into hospital have been experiencing, particularly over the last couple of years. And that's for all sorts of reasons, not solely, obviously, COVID, but that has had an impact. But it's around the increasing levels of challenge that people experience in their lives and how that interacts with their mental well-being, I think. So, and it's not only our area that's seeing this, it's noted as a national phenomenon, and that's had an ongoing impact on the occupancy levels of the beds that we've got within Swift, and also led to the need to use out-of-area beds. And that means that people in Kirklees have gone away from home to be looked after when they're most ill, which obviously is something that we don't want to happen, but we've kept that to a minimum, and I think in the packet it describes the measures that we've taken around that. I think the other thing to note is that we're still dealing with the requirements of COVID infection prevention and control on our wards. We still have stringent requirements around that, as you can imagine, including people requiring to isolate when they're first admitted, and dealing with outbreaks. And we've actually got a current outbreak at the moment on one of our women's wards in Wakefield. So we will have Kirklees patients on that ward at the moment. So we are still dealing with COVID in very live terms. One of the things that's been a very significant factor, I think, are workforce challenges for us in making sure that we provide high quality care at all times and are able to meet the demands that the acute pathway experience. And that, again, is part of a national challenge in terms of particularly a nursing and professions workforce, but also other impacts as well. And there's a considerable amount of innovation that we're deploying around that in terms of how we're looking at new roles, how we're looking at retention and recruitment differently, how we're partnering up. Obviously, the work that we're doing with council colleagues, we don't actually have council staff working on our wards, but the whole infrastructure that we've got around in the community teams really stands us in good stead about how we can support ward functions in terms of supporting people to be at home as soon as possible, looking at discharge packages, looking at housing solutions and that type of thing. So all that has stood us in very good stead, I think, in dealing with the acute challenges. And it's fair to say as well that we have home-based treatment teams who provide care in the community for people who would otherwise be in hospital. They've experienced similar challenges in terms of the complexity of service users who need their support, and also experience similar challenges in terms of workforce issues. So the programme that we're implementing at the moment, which we are seeing some positive results from already, very much is a global programme throughout the Trust and with partners to make sure that we can optimise that. So in terms of the work that we're doing to reduce the number of people who need to be looked after far away from home, we keep out-of-area placements to a minimum, and we adopt continuity of care principles that have been shared by NHS England around how we can keep contact and reduce the length of time people need to be away from home. And we've have very intensive support to each person when they're on placements, and we're actually seeing good product of that as well, in that we've reduced the number of people down to, I think it was 14 this week, and at the height it was 20. So we're already seeing, as I say, some positive impact. We have patient flow, which is how we look at movement, discharges, people coming in, prioritisation. We have that working 7 days a week, which we didn't have 18 months ago. So that's been a really important progression. And we have senior staff available to patient flow and all the wards and home-based treatment 7 days a week as well. So we don't rely on on-call infrastructure systems. We actually have staff on the ground to support and to provide that leadership and support with the complexity of decision-making, because some of these situations are very challenging when you're looking at people who are experiencing high levels of distress and are very unwell and at risk in the community, and how you can best support them and also prioritise the number of patients we've got in beds at any one time, and how you can manage that safely. So we've found that that's been really helpful. We've also looked at trauma-informed pathways, and we've had considerable investment in Kirklees around that from commissioners, and that's been one of the most important innovations, I think, at looking at collaborative care planning with certain individuals and looking at how we can support from the outset and be very sort of innovative and close nearby with them and enable them to take more responsibility for how they're able to keep themselves well. And we've seen some very positive impact. We're collecting data to support that about how we're reducing their need to come into hospital and giving them far more positive tools, really, to keep themselves well and to keep at home. And then we're also looking very much about how people access our services and how we can improve those pathways so that we can get into people's levels of distress sooner, so that we prevent people coming into an acute period, really, for them, and how we can work with them in the least restrictive way possible. So, as I said, we have had, and I've put the details in the pack, some positive impact on reducing the number of people who were in private out-of-area beds, which is what we want to continue doing. And we are on a trajectory of performance, and we're working with partners in Leeds and Bradford and at ICB level to continue and build on that improvement. So that's just a bit of a focus on the inpatient pathways, and I'm going to ask Melissa now to talk about community transformation, which is a bit of a jump from that, but it is all connected. Is that okay, Melissa? Thank you.
Hello, everybody. I thought I would just give you a quick run through some of the latest ways that we're thinking about, in partnership with NHS England, around delivering community services in a less centralised way, that's less focused on our hubs here in Follyhall and in Dewsbury, and is much more focused around local mental health provision within each of the individual GP surgeries or PCNs within each of your wards or areas. So the programme of community transformation started, I think it was only last year, although it feels a little bit longer than that, where each area was charged with delivering individual model for their locality around how we would want to decentralise, so stop delivering in our big hubs and start looking at how we could provide much better more locally focused, better accessible mental health care delivered right down to the local place. The way that Kirklees has looked at that is we've looked at a variety of different mental health roles. So some less traditional mental health roles than just nurses or social workers. We've broadened the provision out to look at roles such as social prescribers who'll help people find activities and local connections in their local communities to help reduce isolation and help prevent escalation into serious mental health problems. We've looked at people who can deliver physical health care for people with serious mental illness. There's lots of research that says that people who suffer from really serious mental health problems have poorer outcomes in terms of their physical health care. So we wanted to tackle that particular inequality and have developed a team who will sit within the local GP surgeries to deliver that targeted physical health care to people with serious problems in the GPs. We've included within that some very senior advanced nursing roles who will help us manage people who fall into a gap maybe between what the GPs can feel they can manage and how secondary care and the people that meet the secondary care criteria. Sometimes people present with quite a high degree of need who struggle to get into services because we're challenged by high demand, and this transformation will help fill that gap. So we're providing mental health professionals, really senior mental health professionals, into GP surgeries to see those people in a much more fluid way than we would have seen them before. The transformation itself, talking about integration, is delivered in a partnership approach between third sector providers, the trust, the local authority and commissioners within the ICB and as I've said, the local authority. So we're in the very start of this really exciting transformation, which won't just deliver at the local level, it'll have far-reaching effects into the way that we deliver our own community mental health services within the trust, making sure that they're well aligned with these local teams and hubs to ensure that people don't go through multiple assessments, don't have lots of doors to go through to get to where they need to, and to even out service provision so that it becomes a seamless transition between primary and secondary care. It's exciting times. We're only at the beginning of it, and we're hoping very much that it meets the aims of the transformation around improving access, improving physical health care, and improving the ability for people with serious mental health problems to be seen in their local areas. Thank you.
Thank you. So that's it from us really, talking to what we submitted already, and we're just obviously looking forward to any questions and any discussion now. So thank you.
Lovely. Thank you, Chris. Thank you, Michelle, Melissa. That's great. Just before we move on, Vicky, we noticed that you've joined us, and just wondered if you wanted to introduce yourself and just obviously you've got a clear understanding of what's been said.
Yes, thank you, Councillor Ramsey. Yeah, I'm Vicky Dutchburn. I'm the Director of Operational Delivery and Performance for Kirklees Place. So fully on board with everything that you've had explained to you today, taken through in the presentations that you've got, and about the integrated way of working across Kirklees. And I think the only thing that I would like to add, certainly about the transformation work that's ongoing, and it's not just what you've had presented today as in the community primary care transformation work, but also some of the future work that we're in development to take forward, such as our autism work, etc., is that all of that is done in full collaboration with all our system partners, and is done with co-production of our service users. So the model that Melissa has briefly outlined for you today, a lot of the work ahead of even starting to look at recruitment of new workforce, etc., was done with our PCNs and our communities about what was needed, the types of roles, the types of functions that they wanted to support them with their mental health issues to try and improve their mental well-being and that journey if they hit our services. So I think that's the only thing I wanted to add.
Thank you, Vicky. How would you like us to structure questions? Should we do it in the kind of the segments that you've done the presentation in, or are you happy to take random? All right, well, we'll ask Richard to sort them out into the segments later. That's great. Can I just ask members of the panel then, if you would like to ask questions, just to indicate?
It's Alison Monroe here again. So my first question is about community pathways, and I've noted that for example, IAP services. Now I realise they're a go-to service that anybody can initially start a conversation with them and hopefully be assessed. And I think they deal with perhaps more minor, not so serious illnesses in terms of mental health. However, what I have heard from various people who've used the service to say, they were dealt with in good time, but sometimes they may have been discharged earlier than they should have been, and I've just wondered, they're being measured against recovery performance, but I just wondered if perhaps are there? Do you know if there are people who've been treated, who've received treatment through them, perhaps face-to-face treatment, virtual meetings or whatever, but then, are they referred again? Do they come back again to the service, or do they come back again with, do they present with, far worse problems, a year hence or whatever? So I just wondered if this should be measured against other criteria as well. If somebody could just come back to me on those few points I just raised. Thank you.
Hello, thank you for that. There's quite a bit to unpack there. So, as you said, IAPT is a frontline service for primary mental health care, looking after people who have a presentation with either depression or anxiety. And as you say, it has a particular set of performance measures that it's measured against. These aren't locally derived, they're nationally given to us by NHS England. So your question, unfortunately, around would there be a better measure of somebody's progress or somebody's recovery to better mental health? Unfortunately, we have the set of measures that we have. What recovery does is it looks at two questionnaires, one about anxiety, one about depression, and it measures that person's progress from a high score to a low score across their treatment. There is another one that we take, and it looks, rather than a given set of scores, so for somebody to reach recovery, they have to have reduced their set of scores by a given amount but we do look at something that looks at a recovery score that is just more generally based on how much have people improved. So if they started at, say, 15 and 16 on the questionnaires and maybe shifted down to a 9 or a 10, that's a really significant recovery for that intervention, for that person. So those aren't nationally reported, but we do look at those internally to make sure that we are getting what we call reliable improvement, so people shifting down towards better mental health. We do have a function in IAPT which is around making sure that people are on the right part of the pathway. So not everybody is suitable for an IAPT treatment of care, but what we do is make sure that we have excellent links into our secondary care services, so that if people aren't getting better through the treatment that they're being delivered through IAPT, that they've pathways into the rest of our core and enhanced services in order to be able to meet a more serious mental health need. So to answer your question, not everybody gets better from IAPT, but we do try and ensure that if people aren't getting better through that pathway, that they've got the right signposting and the right links into the rest of the services in order to get the treatment that they need.
All right, thank you. So just one other question on that. So do you think there's pressure on the service in terms of people accessing the service? So do you think that could cause problems in terms of them being discharged at the other end? Because there's so much pressure on the people who are running the service to get through all the get through the people who are actually contacting them for help. Is there an extra pressure there that is they're finding difficult to deal with?
It actually, the recovery performance KPI, the measure that we have to take, actually prevents that, because there's a real disincentive to discharge people before they've reached that recovery figure. So actually we don't discharge people early from that service because we nationally measured on their improvement to make sure that they do get better. Is there pressure on the service? Absolutely, there's pressure on all of the services, and demand is higher than the ability to be able to meet it for a lot of the services. But actually for our IAP service, we have another measure that looks at how long people wait before, from the first assessment to the treatment, and from the time that they referred into the service to the time at which they start their first assessment and treatment. And our IAP services are very high performing nationally in all of those. So we don't have high wait times and people don't wait long for their service. And absolutely that recovery KPI, a performance objective, makes sure that people get the treatment that they need and stay in the service. What it is though, is it's a very targeted service. So it does not treat a broad range of people. And I think some criticism gets levelled at it because it's not for everybody. It is only for people suffering very specific needs, but we do pathway them where we can to make sure we meet those.
Turning on my microphone would be helpful. I guess it's also just to reassure, we monitor feedback from a range of sources, including our complaints that we receive into our organisation, and to my knowledge, sat here, it's not a topic that comes up as a regular part of our, or a frequent part of our complaints. I can certainly double check that, but that isn't part of the feedback that we're getting as an organisation.
Thank you very much. I wonder, Stacey, is it worth you inputting into this? Is this something that's heard of from a Health Watch perspective?
In terms of people being discharged early, no, we don't hear particularly a lot of feedback around that. What I will say is the feedback that we do receive is about accessing services and actually getting an appointment. That people find incredibly difficult. Even that might be an appointment to see if they're able to meet the criteria for the service. The one thing that we hear primarily is about CAMHS and children's mental health services, autism assessments, ADHD assessments and things like that, and the waiting times that have been flagged quite a number of times with us over the past, I would say, 5 years. We're getting more and more people saying that they are struggling to either get referrals or meet criteria or even be assessed by anybody. And that was one of my questions actually that I was going to bring up later, but I might as well delve into it now. In terms of the transformation, what are the timelines that we're looking for in terms of getting those kind of PCN roles in place, and what are we looking for beyond that? So I know we talked about KPIs, and there's something for me around KPIs are fine, but actually patients are at the heart of everything that we do. Are we, even though we have a number attached to this person, actually how does a person feel about that number? So that they were just my comments. Thank you.
Thank you, Stacey. Are you all right picking that?
Yes, certainly. Sorry, Stacey, around the community transformation roles, we've started, so we're well underway. We've got many of the mental health roles that I described have already started within the local PCNs and are starting to deliver. It is early doors yet, and we do still have some recruitment to do in order to make sure that we get everybody into place. We're just looking nationally now around outcomes, and as you were saying, it's not all about KPIs, and I'm really pleased to say that the outcomes that we've been looking at nationally are very patient focused. They're very much around how did you find this service, what has it done for you, what's it meant to you in terms of access, what's it meant to you in terms of recovery. So I hope that answers your question. Was there something that I'd missed there?
Just about CAMS and kind of autism assessments, ADHD assessments.
Okay. In terms of children and young people, we actually agreed, Richard, that that was not the scope of this meeting, didn't we? Because we're going to come back, is it in the autumn, to look at that? So we haven't got material prepared for that, Stacey, at the moment. In terms of the autism pathways, we have included a slide there about the service that we offer. If there's any more detailed information that is needed about that, we can always follow that on. But obviously, you'll see from what we've included that the service is a positive one for the people of Kirklees at the moment, and the meeting obviously needs as presented within that sort of diagnostic and needs-based pathway.
Thank you very much. It's just to say as well, obviously we work with the Trust extremely closely, and we provide live intelligence from Healthwatch to the Trust for them to pick up on a quarterly basis. So obviously everything that I've sent to counsellors here today, you've already seen in terms of patient experiences.
Thank you. Thanks.
I'll open it up. Kim. Thank you. One of the questions that I have is around waiting times, particularly into access to secondary mental health care. And just to kind of understand the challenges and setting the scene in more detail, really. So following an initial assessment, how long might a service user, new referral, typically wait to actually start their agreed treatment? And is that in any way communicated to the service user? So I'm kind of scanned the Healthwatch survey, and a lot of the issues around communication and people just not knowing where they are, what pathway, and who do I go to for help. What kind of communication plans do we have to communicate the waiting times, which I understand are going to be extensive, but I just wondered whether you can quantify those for me.
Thank you. So obviously within the acute pathway, we don't have any waits at all. We work with people on a 4-hour assessment basis, or a 1 hour if they present in accident and emergency departments, and people come straight in and obviously their needs are met in the way that they need to be met in a crisis. Within the routine pathways, which is what we could, we have 14 days prior to assessment width of time, and not wanting to keep talking about KPIs, but that's broadly met, and very much so for the people of Kirklees. And then we have an inter-treatment expectation within 6 weeks. So that means that by that point they'll have a care plan, they'll have had some interventions, and they'll be being worked with by a coordinator or a lead professional. What we do have, following on from that, are people who may need particular interventions in addition to their usual care plan, and that could be part of a therapeutic programme for them. So, for example, I might need to be seen by an individual coordinator, but I might need to undertake group work for a particular problem, and then I may well, following my group work, want to be seen by a particular therapeutic practitioner. So those start to build up the times that I wait for each of those things, but quite often that could be for a therapeutic reason for my own purposes. But then we do have intense demand on services. We have growing demand on services, and I think one of the slides that we included was around the projected increased demand, which unfortunately we're already seeing the consequences of. So for those people who are waiting, and it's usually for the more complex psychological therapy type interventions, we have a wrap around that person of a safety net, a point of contact, and regular reviews, so that we make sure that they know what's happening. We don't say to people, by the 30th of October, you'll be doing this, that and the other. We can't tell them that, because you know, you actually don't know that, because a lot of the resource is taken up by people's own therapeutic journeys, so you have to make sure that you've not given false expectations. But we have points of contact, we have reviews, we have other things that they may be experiencing or we're delivering with them prior to their specialist therapy or whatever. And then we keep the risk under review as well. Melissa, it may be good for Melissa just to give you a bit more detail about, because she works directly with those teams, but we do receive positive service user feedback on how people have experienced that. And we've actually, at the moment, we're engaged in a waiting list programme across our services so that we can improve that and make it more person-centred and make it more standardised as well, so that people would have information up front about how they will be looked after and supported during that period. I don't know if there's anything that you feel you can usefully add there, Melissa. Just what I want to say, the point of contact is with a professional colleague as well, and it's a named person, so that you would know. Okay. I would know who was going to ring me in, let's say now it's July. I've a book call with somebody, say August the 12th or something, and then I might speak to them again in September or whenever it was considered a good balance. But I'd know who it was, and I'd know how to contact them in the interim. I don't know if there's anything I've not covered there, Melissa.
I think you probably covered most of it, Chris, thank you. But yeah, absolutely, to reinforce it, that in the services where there is a wait, which is particularly around our psychological therapies, where there's a very particular therapy, for example, group therapy, or one of the therapies that maybe only one or two of our therapists can deliver, we ensure that people during that wait time have a named person to go to, that they've got a point of contact, and that they're clear about who to contact should their mental health deteriorate, and how to get into contact with the services both in hours and out of hours to make sure that they've got that wraparound.
Thank you, that's really helpful.
I was just going to say one other thing. The work that we're doing around the waiting times trust-wide, we're actually cross-referencing that with information that we've got about equalities and different populations and demographics, so that we're looking to measure the impact on different people and their experiences and how they can access our services to make sure that we're not discriminating against any particular group. So we've got some very rich data that's emerging now that we're using, getting more sophisticated at using that and getting support. And we're actually employing some new resource to help frontline services with that.
Thank you, that's really helpful. Thank you.
Daryl, is there something you can add? Yeah, thank you.
Yes, I was going to mention the equality, so it's to make sure we're not having an unduly negative impact on particular parts of our population. I guess just to assure panel, waiting times is a regular focus at our Clinical Governance, Clinical Safety Committee and at board, and that's not only on the numerical waiting times or the as a number of people waiting or length of time waiting, but also on the experience of people who are waiting and any incidents that occurred over that time. So we're triangulating the information that we have around that topic. Just to also mention that one of our new quality priorities for this year, we've got 3 new quality priorities, is safe and responsive care. So that's clearly a focus and a declaration from the organisation around the responsive part of that statement.
Thank you very much. Just to make sure we welcome Carol. Thank you for joining us, Carol. And Bill, if you want to ask questions, please will you use your hand. Same again, Liz, if that's all right. Was there anybody else in the room at this stage that wanted to? Is that yourself, Leslie?
Yes, please. Hi. Yeah, I mean, clearly there were challenges everywhere, as you would expect at the moment, and it was sort of expected and yet worrying, where you talk about the significant relapse of many service users' mental health that had been stable. And I just wondered, you talk about developing a crisis house. I just wondered at what stage that is at development and whether that is something that is realistically possibly going to be in place if we have another bad winter, for example.
We're looking at a range of options for individuals, and when we say crisis house as well, that's just one of them, because we're looking at how we can work predominantly with people in their own homes, as close to their own homes as possible, and utilise our crisis cafes and our support from the community and voluntary sector, as well as our own resources, right including as well police liaison and the whole range of responses to people when they get into high levels of distress. But we're working very closely with partners and commissioners to look at appropriate accommodation, how we link that with existing services, and how we can get something in place as soon as possible using, I think, existing resources really, so that we're not saying we've got a long lead-in time for this, because we recognise that people's needs are right and immediate and we need to be doing something. We've done some quite innovative work, for example, and commissioners have been really, the CCG have been really supportive with this, with Enfield Down, which is a rehabilitation unit that is it's based in Honley, serves the needs of people throughout Kirklees. And we've actually done some quite innovative work there where people wouldn't really be going into a rehabilitation pathway, but we can use accommodation which the local authority support as well, short term, to enable them to stay as close to home as possible, stay in as usual setting as possible in terms of like flat-like accommodation, whilst having access to support of the crisis team and home-based treatment, and also staff support 24/7 at Enfield Down. So we're already using some of the principles of the work that we're trying to implement in terms of crisis house. And we've got the crisis cafe provision, the well-being cafe, which I think we've put in there, which is receiving really positive feedback about how people experience support there. So I'm not able to answer your question definitely, like we'll have it by October or we'll have it by November, but we're working very hard at the moment to source suitable premises and to build on what we're doing already. But in the meantime, we are actually working on an individual basis, and the services are linking up well around that, and we're building a bit of an evidence base really about it. It doesn't all have to be buildings based.
Can I just ask, when you mention the cafes, what sort of numbers do you get attending them? I mean, are they well used on a regular basis? Because I know sort of in the valley, when I mention them to people who might find them useful, it's, you know, as you can expect, it's going into Huddersfield. I mean, we have our own community cafes, for example, in Flowett or wherever, and that does reach some people. So I just wondered how the central ones in Huddersfield, and do we have a quite reasonable turnout?
I haven't got data around that, but I think Vicky may, Paul Howatson, who's been leading on this from the CCG, will be able to provide that to committee, so that might be interesting. We are having really rich qualitative feedback come through, and it would appear that people are using them and the centres are busy, but we have got some really positive service user experience stories that service users are kindly sharing with us that we're able to use, and at the Alliance meeting last week we had a presentation about that. But I acknowledge there that they are centrally based, and we do need to keep thinking about that responsive geography, which I think is really around the clue there that not everything, you can't think in terms of buildings, you've got to think about in terms of people's usual experience and make that reach as wide as possible. That's not always easy, but we're very conscious of that it's got to be in all communities rather than just like the centralised ones, Dewsbury, Huddersfield, whatever.
Thank you. Thank you, Chris. Vicky, I know I can see that your waiting list. Can you just let Vicky see if she can answer on a kind of attendance at the wellbeing cafes?
Yeah, thank you. We have two wellbeing cafes. We have one in Huddersfield Central, and we also have one that works out of Dewsbury. The Huddersfield one is used much more frequently than the Dewsbury one. Though it is picking up now in Dewsbury, and we don't know if that's just been about the location, because we are in the process of changing the location because service users fed back that they didn't always feel safe going to the wellbeing cafe in Dewsbury, and it was about the siting of the location, especially when people were coming out in the early hours of the morning if they were going in the evenings. The both are used. What we are able to do is people can drop in as long as they ring up in advance to say that they're turning up, so staff know to unlock doors, etc., if it is late in the evening. And what we are also able to do is offer people one-to-one support through the clinics. Now, sometimes that's not always at the time that they're choosing, because the slots might get used up, but there are always slots available every night. We make sure that they are available for people to utilise, and staff will stay on a little bit longer if people are coming and still need that support. In addition to the wellbeing cafes, it's worth saying we also have a 24-hour helpline. So people can use the helpline at any time. It's a free phone number that we have available for that. And what we do find is that there are some service users that use both. So they might start with the helpline and then want face-to-face and want to go in and actually meet with people. So they will be signposted and get a slot in to go into our wellbeing cafes. But equally, people move the other way. So they might start with the wellbeing cafes, and as they start to feel more confident, then are happy using the helpline numbers. So they're all part of an integrated pathway. It's not one or the other. People can sort of flex and use as required.
Thank you, Vicky. I'll bring you in, Liz, and then I hope you don't mind, but I'd like to ask a question on this one as well.
My question is not on this, so do you want to go first and then yeah?
Thanks. I suppose you mentioned about police liaison, and certainly if you go back a few years, and I presume still now, the police have an awful lot to do with the crisis pathway. And I'm just trying to understand the impact of things like the wellbeing cafes and things like that, and whether that actually stops police having to house clients overnight in cells as a place of safety, or whether that's still something that is happening.
We've developed the holistic response that Vicky's just described in partnership with the police and with ambulance services and with all other sort of stakeholders. You wouldn't say that the wellbeing cafes, at the moment, we won't be able to draw a link between people who can use those spaces as an alternative to, say, being arrested or detained on a Section 136 in the community, etc. But that would be the way forward in people's thinking, that ultimately those preventative services enable people to deal with their levels of distress sooner, so that we wouldn't be seeing as many presentations through to the 136 suite. In terms of people detained on a 136 in the police cells, that is very unusual nowadays, and people are taken to a place of safety either at Calderdale Royal Hospital or at Fieldhead in Wakefield, and that serves the needs of people in Kirklees, South Kirklees and North Kirklees, and we work collaboratively across so that we optimise the usage in those suites. So it's all part of a developing picture really about people being able to be supported at an earlier stage of their challenges. But at the moment we wouldn't have any data to support the introduction of a wellbeing cafe and people's attendance at that had prevented a further down the line admission, or was a direct alternative to detention by the police on a 136 or an arrest for a criminal offence.
Thank you. Liz?
Yeah, thanks. I've got a couple of questions. The first is about the single point of contact going into merging with our single point of access. If somebody makes the call and rings for help, and they can be helped by a community group or something that will help them. Previously, we heard quite a while ago that they were having to make another call because the single point of contact couldn't contact the community group with their details, and then the community group reach out to them. So in other words, people were having to reach out twice for help. So is that changing, or has that changed? Is the better liaison between the SPA and the different groups that help people? And when you're talking about out of area, are you talking about out of area in Kirklees or out of area in West Yorkshire? And what are there any plans to increase capacity locally? And also previously we heard that men between certain ages in Kirklees were needing acute help in mental health services. And I just wondered if that profile had changed or whether it's the same. Thank you.
Okay, thank you. I'm just going to touch on the out of area question first, and then Melissa's going to talk about the single point of access and contact, etc. In terms of out of area, we have got people, when we're not able to look after people locally in the acute beds that we have got people who are distributed around the country, unfortunately, in private sector beds. And obviously we work to reduce that distance whenever possible, and we reduce the length of time that people spend there, and we bring them back home as soon as possible. However, we haven't got much control over that, because if it's an emergency situation, which this often is because there's no other alternative to admission at that point, people unfortunately do end up having to go quite far away from home. And we build individual packages around that as well, in terms of supporting ongoing contact and how we can support relatives, etc. I think it's fair to say that there are no plans to increase the number of beds that are commissioned from us by the CCG. I think that's fair to say. I think that we want to work with people as close to home as possible, but that is not really to say that we want to bring them into hospital locally more. We want to be able to prevent them coming into hospital and to manage the inpatient resources that we've got more effectively, so that we can break through this cycle that we've got at the moment of having to use out of area beds. But I don't think, unless Vicky has a different view, that we're talking about more beds being commissioned from us. We have been on a pathway for many years now of investing in community services so that we can do what most people want, which is support them at home and them not having to come into hospital. And that's the continued emphasis for us, really. So reducing the length of time they stay in hospital as well once they're in. Just to say, and I know this sounds historical now, but up until August last year, we'd maintained a very, very low number of people out of area. And that was down to probably 2 or 3 who were there for very specific reasons, in terms of gender-specific psychiatric intensive care provision, or very clear safeguarding issues that meant that they needed to be far away from home. So it is possible to resolve this. We have done it before and we will do it again. I think it's the conflagration of circumstances that we've experienced that's led us to have the impact of having to use more beds. But I don't think that the answer is more beds in Kirklees or Wakefield or Calderdale. It is actually looking after people in their own homes and getting people back to their own homes as soon as possible. So that's just that basis. On the point about men coming into the acute pathway more than they should do in terms of representation, some of the work that we said about equalities and the different populations and the demographics that Daryl referenced as well, that is helping us understand how people use our services from different backgrounds and obviously different genders, and what we might be doing to prevent overusage by certain groups, etc. We're not seeing a disproportionate number of male service users coming forward in terms of demand at the moment, but it does vary, and I don't think we understand enough about that, so it is very much work in progress. At the moment, for example, we have far more female acute demand than we have male, but a couple of weeks ago it was the other way around. So we're constantly working on that and checking and balancing ourselves and how we respond to that. But we do have some ability on some wards to flex provision, in that we have what we call swing areas, so that we're able to concertina doors and make one ward bigger and one ward smaller. And that's really something that came from estate modernisation. It's been a positive boon. And so we are able to accommodate more men at times and more women at times. It's not always as easy as that, but we are starting to respond to that change in demand. Yeah. Daryl just wants to add to that, so I'll put mine.
Yeah, thank you, Chris. I guess just to flag the increase in out of area, it wasn't something that just happened. It was a strategic decision by the executive management team as a way of supporting safe and effective care on the wards. So it was recognition of the staffing challenges we had through COVID at that time and the particular acuity. So we have applied significant improvement capability to this before, haven't we, Chris, with exceptional outcomes. We still have that same improvement capability in the organisation, so we're confident that we will move that forward.
Obviously, there's the other 2 parts of Lizzie's question that need addressing, but obviously you did describe an over 100% bed occupancy rate as well in your report. So yeah.
Yeah, I think we've have we answered other than the SPA now, your points, and Melissa, go on to SPA.
Yeah, I think it was concerned about the capacity in the system. If you've got a lot of people out of area, that yes, for some it will be necessary to be out of area,
Yeah.
but for others it would be more helpful to be
It would.
nearer home, if you
It
see
would.
what I mean, and have support. And therefore I was concerned as to whether this would be a sustained problem with increased numbers in out of area as your demand is increasing. Yeah, okay. But yeah, the SPA, I'd like to know about the SPA. Yeah, thanks, Steph.
Just before you go on to SPA, Vicky, were you going to come in on the out of areas?
I was, yes, please. It was just to say that as Chris has described, prior to COVID and up to last August, we were the best performing across West Yorkshire regarding out of districts, and it was in those rare circumstances that we were having to use it. It was a decision that was taken. If I say a planned decision, it sounds like we anticipated we were going to get all these people out of area, but it was a planned decision to help us manage the COVID outbreaks, etc., that we started using out of district placements again. What we have, and I know that Chris has mentioned this, is we have set a trajectory to bring that back down and get back to where we were previously. So we are actively working to that. And I think it's worth noting that as a West Yorkshire ICB, we are working collectively on this across all our pathways as well. So for the areas that Chris has mentioned where it's psychiatric intensive care and for very specialised reasons, we are working on that work stream to see what we can do more collectively for those small numbers of people, so that hopefully in the future the out of area placement will be no further than Leeds or Bradford, as opposed to going outside of West Yorkshire.
Thank you.
Thank you. So just briefly to pick up the question that you asked around SPA and whether or not people needed to come back in for referral to outside agencies. There still will be elements of confidentiality where we need to ensure that we've got service users explicit agreement that we can pass the details on around their mental ill health or the problem to the service that we need. So that could potentially cause some delay. Additionally, we need to check sometimes with people to ensure that we're moving them on to the right service. So there is a potential that will always be in place, because confidentiality of that individual has to be one of our key principles that we work to. What I would say is that the development of the local mental health hubs that I was describing earlier also include a role for social prescribing, which is very much around working with our voluntary sector. So there won't be that delay, because the hope is that people will be able to, rather than phone into our SPA or our single point of contact and have a distanced appointment, that people will be able to present at their local GP surgeries, see a mental health professional who will then be able to link them in with the social prescribers, who will be able to then pathway them onto the most appropriate third sector provider or trust provider in the area. So reducing those delays and making sure that everything's sorted out in a one-stop shop in the local area.
We've got Bill. Bill, just 2 seconds while I ask this, because I was going to ask something about the primary care networks and the access through GP surgeries. So obviously, if you're accessing through GP surgeries, presumably that's a certain number of GP surgeries that you're accessing through, not all GP surgeries, because you can't have the experts in all GP surgeries. So presumably, is that one per primary care network? And if we're expecting people to drop into a GP surgery to access not just when they've got serious mental health issues to get some physical support, but also to talk about issues that are bubbling. Are we being realistic about what we're actually putting on those mental health staff that are going to be there? Because I can see them struggling.
Thank you. Yes, it is absolutely per PCN. So the local mental health teams are delivered by PCN. There will be pressure on them because the pressure on GP surgeries in primary care for mental health is already there. So I guess the way that we're conceptualising it is that the demand is already there in the GP surgeries for people with primary mental health care, and that the increased provision can only help ease some of that pressure and help people move into be seen more quickly by qualified mental health professionals at the local place. It is likely that they will have capacity issues from the get-go, because as you say, the demand to see local mental health professionals is going to be high. What I would say is that there's a variety of roles that go into that, so it's not just around focusing on nursing or social care. There's a variety of roles that should mean that people with different needs of mental health provision get seen by the right person who's able to provide a different level of mental health care. For example, the mental health pharmacists, if people need help with prescribing or medication, social prescribers if they need help with social isolation or community development, and then mental health professionals and GPs as they move on.
Okay, I got I got moved on by Richard then. I'll not ask a supplementary. Vicky, is it on this point? Because obviously Bill's still waiting. Okay.
Yeah, it was on the workforce and the modelling. So as Melissa has said, that the new mental health workforce and the transformed mental health workforce is going to be multidisciplinary. So it's not that there'll only be one social prescriber for the whole of Kirklees, and it depends when they're in that clinic. What we've done is we've modelled it on the size of the PCNs. So there will be social prescribers, social prescribing hours into every PCN, as well as ACPs, etc. What we've also done is, because we've modelled it on the size of the practices, some practices may have a higher number of certain workforce than others, or PCNs than others. So some might get 2 social prescribers, whereas some of the smaller ones, it might be 1 based on the way it's been modelled. And the third thing that helped us model up the workforce numbers was discussions with the primary care teams, the practices and the PCNs, about where their pressures were. So that supported how we've done the recruitment. So some practices have gone for some of the workforce ahead of others, because that's where they've seen their pressures. So, but over the 3 years of doing this transformation programme, and we've set it as a 3-year programme, by the end of that time, each of the PCNs will have a new multidisciplinary workforce within that, which will include a whole range of different professionals and skills.
And this is in addition to the workforce that was there already. It's not a move.
Yeah, so what the first stage, so there's 2 bits to the community transformation programme. One is new workforce and new skill sets, and the other bit is about transforming what you already had, so you make it more efficient and more effective. And we're doing them in parallel, if I'm perfectly honest. We've modernised and transformed some of our existing work. So Melissa's already talked about the IAP service, and what we did with transformation of the IAP service is there's a core team that I suppose is centrally based, but equally then what we have what we call the tripartite workers that work into the PCN. So there's 3 workers into each PCN. So we've done that piece of transformation. But then the social prescribers, the new mental health pharmacists, they're all new roles that are being developed and added in as well. So there's a mixture of the 2.
Thank you. Is it all right? Bill, do you want to ask your question then?
Yes, please. It's perhaps more commentary than question. I'm certainly not being critical, let me make that clear. But it does appear to me that very largely this is a fire brigade model of service. In other words, it's reactive. And it might be that that is the only possible way we can deliver these services. But I'm just wondering if there's any scope for a proactive arm to it, a proactive branch to the service, so we try and pick problems up before people actually feel they need to pick a phone up. Can we look at being more proactive? Obviously, it's easy to say, and obviously it's very difficult to do. But it seems to me that if we can nip a lot of these issues in the bud, so to speak, over time it becomes less resource hungry. But I don't know how you get from here to there. But any response to that? Thank you.
Thank you. Sorry, I didn't know if Vicky was going for a button then. I was just going to say, public health has a wide strategy around well-being and about the investment I know that we've had in Kirklees around that, and all the different initiatives about things that we know keep people at their optimum. And it's all connected, isn't it, with people's experience of socio-economic challenges, housing, poverty, and having meaningful activity and meaningful relationships. And there's a huge infrastructure built up by public health, I think, around the communities on this. But also the community transformation that we've been talking about is very much around that preventative work as well. So I think most of the things we've focused on are actually perhaps we've not been able to reflect that as well as we might have done, because it is really around looking very early stages of people, looking at if somebody's got a physical health challenge, how that might translate into a mental health problem, and how you can work with that person as a whole person, using all the resources that are available very close nearby to their usual experience of services, and making links with housing providers, for example, about anticipating challenges in terms of changes in people's tenancies, looking at how we can work with big employers, looking at how we can develop those closer links through the Mental Health Alliance in Kirklees as well, about looking at people's experience as a usual experience and preventing that idea of somebody's become unwell or ill, and how it's just really around well-being. So that whole strategy, I think, wraps around people, but certainly our offer that we've tried to describe today around community transformation is at the very front of that, about working with people before they get into the need for a coordinated service, the need for different professionals to be involved with them, the need for actual treatment or medication or whatever. So it's looking at people's own resources and those in the community around them, so that we can prevent them having to come into a service. And that's for their for positive reasons for people, and also about how we're hoping to manage demand in the future. Nationally, the programme about transformation was about people with serious mental illness, but very much building onto all the work that's been done and the investment that's been around preventative services. And as I say, those broad services that keep people well in their communities. So I hope we're trying to do both, but it does feel a lot of the time, like you say, yes, it feels like we're part of the Fire Brigade, yeah. And we're very grateful to Fire Brigade colleagues as well for being part of our services, because we all work so well collaboratively, and they're great colleagues. So thank you for that.
Thank you, Chris. I think unless there's anything urgent, we've just got one more question. So do you want to go ahead, Helen?
Thank you. Obviously from the report, there are clearly a number of challenges for the service. Excuse me. And there's obviously a lot of very positive work going on. I just wondered, in the report, there are a number of issues where there's work towards, etc. And I wondered if at some point it would be possible to feed back on that and about what's been achieved and how that was achieved and sort of when. But I suppose my real question is, in terms of those challenges, and that ranges from the people who work with you as well as the people who work for you, what's the number one biggest challenge that you think you have going forward? Because there are many, but what's the overarching one? What's the biggest one?
So thank you for the reference to coming back and talking again in the future about the realisation of some of the work that we've got in progress. That I think that'd be very welcome. We may have a different answer to this, but I think one, if you ask me for one, I could give you two probably, but if you ask me for one, I would say workforce. The ability to be able to deliver services with the right people at the right time in the right place is the biggest challenge that we've got, I think. And we're working on it, we're prioritising it, it's part of our, key, it preoccupies us, and we've, as I say, I hope we've conveyed the innovations and the intensive work that we're doing on that, and we're joining up with colleagues nationally, regionally, and very much partnership approach in Kirklees, which has been hugely positive, but that really would be our biggest challenge, I would say. If that's okay, Daryl's going to come in with...
Do you want to go?
Yeah, I mean, I think I'd echo that. I think I'm glad you said workforce, that was going to be mine. I think from a professional point of view, social workers nationally is they're really hard to source, as are our AMPs. People, and we are working regionally around making sure that there is a one scale of pay, which seems to be a real issue for us, because you can go to Wakefield and get 5,000 more, you can go to Calderdale and they pay 2,000 less. So there is some regional work going on to address some of those issues, Helen, because I think that's becoming more and more evident that people are just jumping across authorities because they can. The cost of living crisis is obviously a massive factor for the workforce, but there is a lot of work going on at the moment with the university to try and engage university, to try and get students really early, apprenticeships, getting sort of people straight out of university, so that there is a really good offer from the council. Whilst we might not pay as much as other local authorities and partners, I think the flexibility that Kirklees offer is really attractive to people. The flexibility in terms of hybrid working, that seems to be the feedback that we're getting from the workforce. But from a professional point of view, it is really difficult. Certainly in terms of maintaining our duties, we are seeing more and more breaches. So I think if we do come back, maybe some data around some of that might be of interest to sort of the panel around how we're managing that and the mitigations to making sure that we're fulfilling our duties, because it is a pressure, massive pressure locally. Thank you.
We asked that same question of ourselves as a board a few weeks ago, and we all agree with Chris. It is our major concern, and we are all thinking about what creative ways can we look at to maintain equality, and at times perhaps improve equality in services, but thinking differently about our establishment. So we have all sorts of activity around that, and that also includes further more immediate term solutions. We are a strong lead in international nurse recruitment, and that's both for mental health nurses and physical health nurses, and we're soon to move into allied health profession international nurse recruitment. I can't call them nurses, that would be really bad. International AHP recruitment. I guess also to think about the feedback and the outcomes. We have a locality section of the integrated performance report, don't we, that is public facing. And so some of that progress will also be captured in that month on month. So just to flag, that is our where we try to be as open as possible about our progress and developments.
Thank you. I really appreciate that. I mean, in terms of the actions, there were some specific ones in here that didn't necessarily, there was work towards and work ongoing, and I just wondered if those specifically that could come back. But I kind of guess the workforce was and we'd not, and that actually really explains why there are some of the pressures in the service. Thank you.
Thank you very much, and thank you. You've given us plenty of your time. We're looking forward to seeing you back, obviously, around the last two items on our work plan for mental health and wellbeing. So we're looking forward to the integrated wellness service, which is some of the stuff that you just started to cover, and around child and adolescent mental health as well. So with Thriving Kirklees, sorry. We'll look forward to that. And it sounds like we should think about potentially at the beginning of the year or next year looking at work in progress and how we move forward with that. Thank you as well for your risk assessment. It does highlight workforce very much so, and for your performance report, that was very useful. And I think if it's all right with you, we won't want the risk assessment every month, but perhaps if the performance report kind of like comes through, that would be very helpful. We can still keep an eye on that.
Yeah, thank you. We'll make arrangements to send it to Richard. Yeah.
Is there anything you'd like me to do around summing up other than that, Richard?
That's fine, as long as that's like a panel.
Okay, all right, just a massive thank you for being so honest around where things are, the actual reality of it and the ambition that you've got, so thank you for that. We are going to just take a 2-minute break just while everybody from your team can get out, so
thank you very much.
You can have a break.
Thank you, everybody.
welcome back. We've just had that short break, just let the mental health team out, and we're now moving on to discuss the work programme for the year. It's still in draft. We'd like to get to a position where we're able to sign it off as it is, although we will have flexibility in here if anything does crop up that we need to ensure that we cover as the year goes on. But before we get to that stage, has anybody got any comments on the work programme as to whether or not we've covered the right things, whether or not we've got the right level of detail within the work programme, so that we're clear about what people will be coming to talk to us about? Carol, it's nice to see you. Do you have any comments on the work programme as is?
No, thank you. Just to say thank you for giving us the opportunity in the last few weeks and months to be part of the conversation about shaping the work programme. It's been really helpful. And I think increasingly what you might see is similar to what we've just witnessed really around the mental health conversation. Is now that we're in a health and care partnership, we anticipate it won't be a case of a commissioner or a provider coming to talk about certain things. What you might find is there's more of a team, and we'll make sure that we work with Richard and colleagues to make sure that we've got the right representation for any particular item, irrespective of whether they work for the Integrated Care Board or the relevant providers. So thank you.
That's great. I thought you were going to pick up workforce as the one thing that we'd picked up from mental health, which I think will be a recurrent theme all year.
Absolutely. I was thinking that. I think it'll come into most things in this programme, actually.
Can I invite any comments from any panel members? Whether Liz, Bill, online, you've got any comments? Oh, sorry, Stacey as well, you're there.
Is this on any aspect of the work programme? Yeah, because what I wanted to, when we look at the mental health, I'm particularly interested in some of the changes that are going on with the young, with the new mental health support team that's being set up, that sort of changed the way mental health was being delivered in Kirklees. And when I say, I mean the mental health, the mental health support team, MHST. And what I'm interested in is, could we, given that it's fairly new this year, and as yet I don't think Combe Valley's even, I think Goldcrest, but Combe Valley isn't at the moment, and we've lost a really thriving, as I mentioned on Monday, to mention the ladder group again, I'd be keen that Scrutiny actually looks at just how effectively this MS, the new mental health support team, is working, because the limited feedback I've been able to find so far, there are questions about, are there actually going to be extra additional staff provided? Some initial feedback from somewhere had been that the counselling that the young people are currently being offered through this being delivered in the schools is more like a Senko delivering it, and not necessarily a fully qualified counsellor, which is what kids really do need. And given that quite a lot of Senkos these days do not have the thorough training that they were once always teachers who'd had a lot of background. So I am just a bit concerned that I'd like to see how this has worked before the end of this year, if that's possible.
Can I just clarify with you? Are you talking about the actual move from place-based work into primary care networks, and some work that was specifically commissioned in a place-based work stream?
Yes. I probably don't always use the right words, but
that's fine.
Just this mental health support team is what I've become to know it as.
All right. So you're talking about a specific piece of work that was around supporting mental health through education in that area. We have got place-based, we have got primary care networks scheduled. Let me just work out where
it's just ensuring that the delivery is of the standard that will help to deliver these incredible queues and delays that currently are experienced with CAMS, etc.
Right, where have we got them? Carol, I think we've got primary care networks coming under some of the integration stuff, haven't we, and reporting back from yourself. Is that something that we can have a look at, how the primary care networks are able to, because it's all about the place, isn't it? So, because other places may not commission that particular stream of work, they might think that something else is more important. Can we look at it in that?
I think there's aspects of what I've just heard that definitely fall into that integration of health and adult social care theme, but I also wondered if those part of it might be picked up as part of the conversation you alluded to earlier around children's and, you know, children and young people's mental health services. I don't know if there's also a connection in there, so maybe just need to do a bit of mapping out as to where the discussion would most logically fall, if that would make sense with something we could pick up with Richard.
Okay, we'll make sure that we've accommodated that, Leslie. We believe it's in already, or it can be. So, and we'll just make sure, and I'm sure you won't let us forget. Okay. Bill, you've got your hand up.
Yes, just to pick up on what I said earlier, about issues that I'm aware of, about rheumatology in particular. Looking at item 3, which I take your advice, it would cover it, but can we just alter the wording a little bit? In line 2 of item 3, manage demand and catch up with delayed planned surgery and diagnostics. Can we include therapeutics after surgery? Planned surgery, therapeutics and diagnostics. And it would then cover that issue entirely. It could be brought up if I wished under that heading.
I can't see any reason why not. Can anybody else? No, we're happy with that, Bill. Thank you.
Thank you.
Anybody else got anything that they would like to contribute to the work programme?
Sorry, it's me again. Just the end-of-life care. Again, talking personally, clearly my partner was lucky enough to end up in Kirkwood Hospice, which is just heaven on earth for what it's delivering. The concern I experienced was with when you need end-of-life meds in the middle of the night. Locala were struggling to put more than one team on for the whole of Kirklees. I don't know how often that happens, but when I talk to the staff, they just say there is a lot of stress involved in the work, is the way I'd put it, and that there aren't enough staff on. And I just like, you know, again, that to be looked on. We had a delay waiting for them, and, you know, it was very difficult.
Yes, I think we can cover that, but it may be something more specific that we want to do around providing that home support for terminal patients 24/7 that we might want to have a look at. I don't know how people feel about that. Stacey, you've got your hand up.
It's not related to this topic, so I can wait.
How would we like to put that in? Do we want to reference the fact that, you know, if people choose to be nursed at home, that we've got a service that actually matches that? So we include that at that stage.
Under the end of life care.
Under end of life theme, yes, because it is a choice. Thank you for that, Leslie. Helen?
It was just on the CQC, quality of care in Kirklees, and just really it's just along the same path. But would it be possible for us to have information about what are the areas of concern? I don't know if that's what normally happens in terms of getting a quality report on what's going well, what's not going well within the providers in Kirklees.
Go on, Richard Hughes.
Yeah, I mean, in the past, what we've done is we have invited CQC to attend a panel meeting to present with a Kirklees lens the quality of care in Kirklees across all the various areas that they cover, and that's been helpful to the panel in some respects, in terms of it gives gives an overview and a context in terms of how each area that they monitor is performing. So we've got it on the work programme because what we said is that there was a question about the value of actually having them physically come here and do a presentation, which is fine. And in the past we've had some reasonable discussions and conversations through that. But also we thought it might be helpful just to maybe have that information bit. I think Jackie has already said she'd be quite keen for us to use data and performance information to help inform our work. So what I can do is I can approach CQC and request that type of information, which we can circulate to panel members. That can then, if there are any issues that are highlighted from that information, we can make a decision in terms of how we then take that forward as part of the work programme. So we can utilise that information to help inform our work.
I think that would help us with each of these other themes as well, just to have that as a baseline about whether overall those services are performing well. It's just another check for each of these that we're looking at. So that might be helpful to have something like that. Thank you.
Thank you for that, Helen. Sorry about that, Stacey. I parked you and then forgot to come back to you. Off you
It's
go.
all right, no problem. It's not a comment about the work plan, it's more of an offer. I would like to offer that Health Watch bring patients or patient stories based around the work plan, so that you also the panel get kind of the other side of the coin as well. So obviously the one that stands out to me as always is dentistry, because it seems that Health Watch can only talk about dentistry. In terms of bringing people into this meeting to share their experiences, or videos of people who are sharing their experiences of what it's actually like in Kirklees to use these services. And I'm just wondering if that would be of interest. Obviously, I've sent some patient feedback, but actually having a real person in the room or a video is totally different in terms of people's stories.
Thank you. I'm not 100% certain about the real person in the room, although I will open it up to the panel. It's just that in my experience, it seems to take an awful lot longer. But I love the idea about the patient stories and the videos. And that is something I think we should incorporate. But I've just said my view, but other people think having the patient in the room will be helpful.
I think having a real life story in whatever format it takes is really important, and I think that kind of, if that is then representative of the experience of people, that's really helpful. Obviously, if it's a one-off, it's not necessarily representative. But I also wondered as well about people with a learning disability with a we've mentioned mental health in the work programme, but I suspect that for people with a learning disability who don't necessarily access dentistry at all, and that maybe the support isn't there to allow them to do that. So I don't know if that's your experience as well. But rather than just having just mental health in there, I think it would be helpful to widen that scope.
Right, so thank you, Stacey, because on the work programmes you've probably seen we have some golden threads, and included in the golden thread is patient perspective, reality of care, patient story. So I think your offer is, obviously being gratefully received, and I think we'd probably want to ensure we have that sort of perspective in all of the conversations that we have throughout the work programme. We have got dentistry on the work programme. We do need to give some consideration to that, because I think I'm right saying this, Carol, that the commissioning for dentistry is moving to the ICS. That's correct, isn't it? Later this year.
From the 1st of April next year, Richard, formally, there will inevitably be some shadow working as we move into that, but the legal transfer in terms of the responsibility would be from the 1st of April 23.
right? So obviously there's that issue that we obviously need to obviously bear in mind. But I think there are elements within the theme under access to entry that we could probably cover from a Kirklees perspective. So I think what we can do is give some thought, with the panel in terms of how we pull out the elements of dentistry that are relevant to Kirklees. I think things like, oral health in Kirklees is obviously one issue. I think there was an issue, I think you might have highlighted it, about orthodontics. I think there's quite a long waiting list for that. The issues around people with severe mental health and how they access services, again, is that. There's the voluntary aspects as well. So I think there's quite a number of areas within dentistry that we could, as a panel, cover in advance of that transfer. Yeah.
Just to widen it, just to accommodate Helen's, I do think considering support access for people with severe mental health is perhaps too narrow, and perhaps what we could put is something around people that have that have vulnerability or something, so that we can cover a much wider spectrum. And I'm really conscious, and I'm not sure whether we did actually put it in as something around care homes, so that could potentially go in under vulnerability. It'd be a bit of catch-all, do you think? Okay, so unless anybody else has got any additional feedback on this, another couple of things that I picked up yesterday was one we had committed in our in a previous meeting, a previous work plan, that we would cover excess death rates, and we're going to put that in under COVID-19, so excess deaths. And then there was some discussion yesterday at the Overview Management Committee, Overview and Scrutiny Management Committee, about some joint work potentially between children's scrutiny and adult scrutiny around SEND and that that transferring of service from children's services through to adult social care, which I think we'll add at some stage. But this is never a final programme. There will be things that come up and crop up, but at least if we can sign it off at the beginning of this year as this is where we're aiming to go to, that'll be helpful. Does anybody else want to say anything on this before we allow Richard to take it away and come up with a final copy?
Before we finish the conversation, it would be quite helpful just to also maybe touch upon the agenda plan. So we've got sort of an idea in terms of what's coming up, and also maybe panel's views in terms of some of the items we can prioritise.
Yeah, that's lovely. So if we're looking at it now from when we're scheduling, we have firmed up in September that we're scheduling unplanned care and maternity. And we did have a discussion earlier, which was around we probably can only concentrate on two. If you think about mental health, and there'll only be two that we actually cover in each time. But I don't think we've got anything beyond there, have we?
We have some provisional options to look at. So, September, I think, is sorted now. So some planned care, discussion, maternity services. October, I have provisionally included dentistry on. And obviously we just need to be clear about what aspects of dentistry we would look to cover. And I also had the impact of COVID-19 down as a potential for October as well. And then in December, we got down the new plan for adult social care reform. So that's, at the moment, that's it in terms of the forward plan. What I will say is that following comments from Jackie, what I will do is I'm going to incorporate the agenda plan into the work programme, so when it gets circulated out, as well as actually having the detail of the work programme itself, will include the forward plan in that, so you can see what's coming up, and obviously then if you've got any suggestions in terms of scheduling or priorities, we can obviously include that as, within that agenda plan. I don't know what members feel about that, whether they're comfortable with that or whether they feel there are other priorities that they feel should come forward. Obviously we've got a lot on, and I think as Jackie has mentioned, it's going to be difficult probably if we're going to have a proper debate and discussion to do more than 2 per meeting. It's not to say we can't, it's obviously to get a thorough conversation, it's going to be obviously quite difficult.
In relation to dentistry, you said you've got to decide yet which aspects of it we want to go address. But I've had it actually raised with me about women who are pregnant, access to dental, access to NHS dental health is impossible. So I would like that to be looked at, because I think, you know, that's when women's teeth can really suffer, gums and everything, while you're pregnant. And if they can't get access to a dentist for treatment, then I think we should be looking at that. Yeah, thanks.
Okay, yes, we can cover that. Again, it's just about what's going to be at West Yorkshire level and what we can do with the Kirklees lens. But yeah, we can cover that.
Carol, would you have any suggestions in terms of the dentistry item for this local panel? Because I am conscious, obviously, there is stuff that I don't want to necessarily cover that will obviously be more from a West Yorkshire perspective. This is very much around the Kirklees lens, and there are elements of dentistry that we can look at from a Kirklees lens, but I don't want to widen it unnecessarily, particularly if we haven't got the right people around the table.
That's what was going through my head, Richard. Actually, I was just making a little note to myself to contact you after this, maybe just to set up a conversation offline about making best use of that session and who would be the right people to have there, given that, you know, former CCG colleagues haven't been part of this for some time, but equally that, you know, that's not an excuse. That's not to say we don't want to get the right people there, but it has to be people who've been close to the issues and can answer the questions. And then there's I suppose there's an element of the conversation that's about what the future looks like and how we build this into a local plan. So would that be okay if we could have a separate? Yes, that was the other thing, Councillor Smage, it was in my head. I absolutely think there would need to be public health involvement in that conversation. So would that be all right, Richard, if we could pick up a little separate planning conversation about that one separately?
Yes, I'm happy to do that. I can arrange that for myself and Councillor Ramsey, yeah.
Yes, and I've seen your comments, Liz, and I think public health are actually going to be pretty much round the table all year. It was just this one meeting that they couldn't attend. That's all. Right, okay, so with that, I'm going to... Oh, Leslie.
Leslie again, sorry. I just wanted to check on the number of meetings, because and if I remember rightly, there was due to be a meeting in April that got cancelled. And I didn't know why. Was it because it's subject to that embargo once elections? You know, I just felt really sad because there were so many issues I'd hoped to bring up, and suddenly it was pulled.
Yeah, it's quite a quick response. It wouldn't have been quorate. We didn't have sufficient enough members available to attend for it to be a meeting that would be classed as quorate. So that's the reason why it was cancelled.
So is it possible that, I don't know how you do this, but if people know in advance, so I can tell sadly people now that I won't be able to come in the September meeting, that if we knew in advance enough that people might, obviously there's the unforeseen, but if people know that it clashes with something professional, personal, that we could reschedule a meeting? Or is that not possible because of the IT support and so on? I just felt it was really sad that at the end of that year, when I thought there were quite a few issues to bring up, we couldn't meet.
Yeah, and I agree. Yes, there's no reason not to reschedule a meeting if we need to, subject to obviously having the resource available to host that meeting. And indeed, we've got the meetings set out for the remainder of this municipal year. And if we feel, as the panel feel, there is a need to, for example, add additional meetings, then we can do that as well. So it's really down to the panel. We will support the wishes of the panel, and obviously, and Jackie as lead member as well. And one of the things I'm also keen to try and do as well is arrange, if we can, some visits, you know, in terms of actually going out and physically seeing and speaking to and, you know, frontline workers and looking at some of the frontline services. So, you know, we can do things around, not just having these formal meetings, but also looking at other activities if members are happy to do that and want to do that. So we, you know, so we can do lots of different things in terms of how we approach this programme.
Right, okay, so we're going to sign the programme off. We're going to agree that we'll prioritise the dates that we've already got in our diaries if we possibly can, and if not, make sure that Richard knows so that we can make sure that we are correct, and we've got that opportunity to hold extra meetings if we jointly feel that that's appropriate. So, with that in mind, I'm about to draw us to a close, unless anybody's got anything that they really want to say. Not Leslie though, no, just joking. Just joking. So, anything from anybody? Carol, no? Bill, you all right? I think he's frozen.
Yeah, yes, I'm fine. Fine, thank you.
Okay, all right. Well, thank you. Thank you very much, everybody, for attending, and we'll look forward to seeing you whenever the next meeting is. I've forgotten. Okay.
6th of September.
Thank you, Stacey. Nice to see you.
Thank you.